Hi, this is Tammy McClish. Let's take a look at radiographic spine positioning. When a patient has a spine radiograph, they might have x-rays of their neck, which is their cervical, their upper back, which is their thoracic, their lower back, which is their lumbar, the back of their pelvis, which is their sacrum, or their tailbone, which is their coccyx. Typically, all of these areas are going to have a centimeter that is going to be greater than 10 centimeters. And because the body part is greater than 10 centimeters, you're going to need to use a grid. Anytime we're using a grid, we're either going to be using it in the upright bucket or in the table. Whenever we use a grid, we need to make sure that our KVP is above 70. So here we're going to use anywhere from 70 to 90 KVP. Our MAS is going to be adequate for sufficient density, and our SID is going to change dependent upon the exam we're going to be utilizing. So please make certain that you keep an eye on when we're going to be using 40 or 72-inch SID. You also need to make sure that you're centering to the IR and you're centered very closely with your collimation. That is extremely critical in digital imaging. Sometimes the doctors will want the patient erect. Sometimes the patient will need to be examined in the recumbent position. Whichever way you're going to be performing your x-rays, you need to make sure that you mark the x-ray either erect or recumbent. With each individual exam, we're going to talk about shielding, dependent upon if it's a male or a female. If there's a potential for pregnancy, do not expose the uterus. And the breathing instructions will vary dependent upon the spine exam. A very important point prior to looking at x-raying a patient is to make sure that you know your topographical landmarks. Make sure that you know them for the cervical spine, thoracic spine, lumbar spine, or sacrum and coccyx. Now basically, you want to make sure that you take a look at the diagram at the bottom, and that will give you an indication of where you're going to find the areas of the body, such as the mastoid tip, all the way down to the distal coccyx. So let's take a look at x-raying a cervical spine. Now typically a cervical spine is going to be a 4-view or more, but you need to make sure that you look at the requisition that comes in from the physician, and you're going to only perform the exams that are indicated. For an AP axial, you can make sure that the patient comes in and you're going to have a 40-inch source to image distance. The patient is going to be positioned supine or erect. You're going to raise the patient's chin slightly as needed so that the CR angle superimposes the mentum of the mandible over the base of the skull. Your part is going to be positioned such that the mid-sagittal plane is centered to the IR. You need to center the IR at the level of C4, which is the inferior margin of the thyroid cartilage, and adjust a line between the upper occlusal plane and the mastoid tip perpendicular to the IR. Shield radiographic tissues if it does not compromise the study. It's very easy to shield the gonads if you're going to be x-raying a patient for a cervical spine. Your central ray is going to be angled 15 to 20 degrees cephalic to enter at C4. And you are actually going to need to take this x-ray when the patient has suspended respiration. You need to have the patient stop breathing for this exposure. If you have a trauma patient, do not remove the cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or the CT scan of the cervical spine. We're looking at the x-rays. We want to make sure we are seeing C3 through T2. We want to see those vertebral bodies and the intervertebral joints. We want to be able to see the intervertebral joints open and the spinous process equal distance to the midline. We want to have optimal density and contrast with no motion. And we want to have soft tissue and bony margins and trabecular markings need to be sharp. Another AP exam is called an open mouth. You can perform this supine or erect, and this exam is also called an atlas and an axis. In this x-ray, you're only going to see cervical 1 and cervical 2. You want to place the patient with the mid-sagittal plane centered to the IR. Adjust the patient's head without opening the mouth. A line from the lower margin of the upper incisors to the base of the skull, which is the mastoid process, is perpendicular to the table and or to your IR, or you want to angle the central ray accordingly. Center the IR to the central ray. As a last step, before making the exposure, hold the patient's head side to side and then have the patient open their mouth wide without moving their head. The central ray is perpendicular to the IR, centered to the open mouth. Respiration is suspended. And for trauma patients, do not remove the cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or the CT scan of the cervical spine. When you're looking at the image, you want to make sure the dens, which is the odontoid process, and the vertebral body of C2. You also want to be able to see the lateral masses and transverse processes of C1 and C1-C2 atlantoaxial joints. Your upper incisors and base of the skull need to be superimposed. The entire dens is demonstrated within the foramen magnum. You want to have optical density and contrast with no motion. You want to have soft tissue and bony margins and trabecular markings sharp. This x-ray is not performed that often. The first picture you're seeing is called the AP FUCHS method, and the second picture you're seeing is a PA Judd method, both for the dens. Patient is going to be supine or erect at 40-inch SID. You're going to want to position the part with the mid-sagittal plane centered to the IR. You want to elevate the chin until the mental meatal line is near perpendicular to the IR. You may also be taking the PA or the Judd method, which means you want to put the chin against the tabletop with the same CR alignment. The central ray is going to be parallel to the mental meatal line, 1 inch infero-posterior to the mastoid tips and the angle of the mandible. You need to have suspended respiration during this exposure. For trauma patients, do not attempt on possible trauma patients. Do not remove the cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or a CAT scan of the cervical spine. When you're looking at the x-ray, the dens or the odontoid process will be within the foramen magnum. The tip of the mandible is not superimposed over the dens. You have symmetric appearance of the mandible, optimal density and contrast with no motion, and soft tissue and bony margins or trabecular markings are sharp. This picture is a PA or AP oblique of the cervical spine. Now, you can obtain this image at a 40-inch SID, but a 72 SID is a preferred SID. You want to position the patient erect. They can be sitting or standing, but it is really much better for you to have them standing. You want to have the entire torso and the head turned 45 degrees to the IR. The central ray, the C-spine is aligned to the CR. Have the patient raise their chin slightly, not a whole lot, just slightly, looking straight ahead. Turn the head slightly toward the IR to prevent superimposition of C1 by the ramus of the mandible. Your central ray is going to be angled 15 to 20 degrees cephalic for a PA oblique and caudad for an AP, and you're going to enter at the level of C4. You're going to have suspended respiration, and do not attempt this view if you have a trauma patient. When you're looking at the image, you want to make sure that you have the intervertebral foramina and pedicles open. You want to have in the LPO or RPO, you want to demonstrate the upside, which is the farthest from the IR, the intervertebral foramina and pedicles. In the LAO or RAO, you want to demonstrate the downside closest to the IR, the intervertebral foramina and pedicles. You want to have intervertebral foramina uniformly open and pedicles in profile. You want to have an optimal density and contrast with no motion. And you want to have soft tissue and bony margins and trabecular marking sharp. Here is a lateral cervical spine. Once again, with your SID, it can be 60 to 72 inches, but the longer SID is better for visualization of C7 because of less divergent rays. Patient is going to be positioned standing or sitting. Erect is preferred. C-spine is aligned and centered to the IR. The top of the IR is going to be 1 to 2 inches above the level of the EAM. You want to elevate the patient's chin slightly, relax and depress both shoulders evenly, and if you can, place weights in both hands. The center ray is going to be perpendicular to the level of C4, which is the upper thyroid cartilage, and you want to expose this on complete expiration. For trauma patients, do not remove cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or the CT scan of the cervical spine. When you're looking at the image, you want to make sure you have C1 through C7 minimum. Intervertebral joint spaces and vertebral bodies are demonstrated. Near superimposition of the zygoapophyseal joints. No superimposition on the mandible on the C-spine. Optimal density and contrast of the lower cervical and upper thoracic spine with no motion. Soft tissue and bony anatomy is visible. Here is a swimmer's view. The SID needs to be 60 to 72. 72 is better because you can have a better visualization of C7 because of the less divergent rays. Patient is going to be seated or standing. Erect is preferred, and the C-spine aligned and centered to the CR. You want to elevate the arm and shoulder closest to the IR and rotate the shoulder slightly anteriorly or posteriorly. The opposite arm is down. You want to relax and depress the shoulder with slight opposite rotation from the other shoulder to separate the humeral heads from the vertebrae. This may also be taken in lateral recumbent position with one arm and shoulder down and one arm or shoulder up. The center ray is going to be perpendicular to the level of T1, which is approximately 1 inch above the level of the jugular notch. And you want to have an optimal 3 to 5 degree caudad angle to separate the two shoulders for patients with limited flexibility. Exposure is going to be on complete expiration, and that is also called, or you want to also have orthostatic breathing technique. For trauma patients, do not remove the cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or the CT scan of the cervical spine. When you're looking at the image, you want to make sure that you have vertebral bodies and intervertebral disc spaces from C7 through T3. That is the minimal number you want to demonstrate. Separation of the humeral heads from the cervical spine, vertebral bodies in lateral perspective, optimal density and contrast of the lower cervical and upper thoracic spine with no motion, and soft tissue and bony anatomy are visible. Here are two images of the cervical spine with hyperflexion and hyperextension. You want to have an SID of 60 to 72. 72 is preferable. Patient is standing or sitting. Erect is preferred. You want to place the patient in a true lateral. The C-spine is aligned to the CR. You want to relax and depress the shoulders as much as possible. In the image that is marked hyperflexion, you want to depress the chin to the chest, and you want to have the entire C-spine on the IR. For hyperflexion, you want to elevate the chin as far as possible, and you want to have the entire C-spine on the IR. Central ray is going to be perpendicular to the level of C4, which is the upper margin of the thyroid cartilage, and you want to expose on full expiration. For trauma patients, do not remove the cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or the CT scan of the cervical spine. When you're looking at the images, you want to have C1 through C7, and what you're going to show is a range of motion and ligament stability. With hyperflexion, you want to see the spinous processes well separated. Hyperflexion, you want to see the spinous processes in close proximity. You want to have optimal density and contrast with no motion. Soft tissue margins are visible and trabecular markings are sharp. Here is a trauma case, and this is a cross-table lateral cervical spine. Your source to image should be 60 to 72. 72 is preferable. Patient is supine with depressed shoulders. You're going to place the patient in a lateral position. Place the image receptor 1 to 2 inches above the level of the EAM, external auditory meatus. Central ray is going to be perpendicular to the level of C4, which is the upper thyroid cartilage, and you're going to expose on full expiration. For trauma patients, do not remove the cervical collar and do not move the head or neck until authorized by a physician who has evaluated the horizontal beam lateral image or CT scan of the cervical spine. Thoracic spine, also called a dorsal spine or a T-spine. For the AP, you want to make sure the SID is 40 inches. Patient can be supine or erect. If they're supine, make sure you have them flex the hips and knees to reduce the lordotic curvature. You're going to position the part with the mid-sagittal plane centered to the IR. Arms are by the sides and shoulders in the same plane. Central ray is going to be perpendicular to T7, and you're going to expose this radiograph on full expiration. When you're evaluating the image, you want to make sure that you have 12 thoracic bodies, intervertebral joint spaces, and spinous process, as well as the transverse processes. You want to have the sternoclavicular joints equal distance from the midline with no rotation. Optimal density and contrast with no motion. And you want to have soft tissue margins visible and trabecular markings are sharp. Lateral thoracic spine, source to image distance is going to be 40 inches. Patient is going to be lateral, recumbent, or erect. You're going to position the part such that you elevate the head to the spine level. You want to extend the arms forward. Place a radiolucent support under the lower thoracic region until the space is horizontal to the tabletop. The central ray is going to be perpendicular to the IR, entering the level of T7. And for respiration, you're going to do what's called orthostatic technique or a breathing technique. It's recommended for a minimum of 2 to 3 seconds, or you can also expose on full inspiration. When you're looking at the image, you want to make sure that you have 12 thoracic bodies, intervertebral joint spaces, and spinous and transverse processes. Intervertebral disc spaces are open. Optimal density and contrast with no motion. Soft tissue margins are visible and trabecular marking are sharp. Lumbar spine x-ray, AP. SID is going to be 40 inches. The patient is going to be supine. Now the patient can also be standing erect, but if they are supine, you want to make sure that you have the patient in the mid-sagittal plane centered to the IR. Flex the knees and hips enough to place the back in firm contact with the table. Central ray is going to be perpendicular to 1.5 inches above the iliac crest. Expose at the end of expiration. When you're evaluating the image, you want to have T12 through S1 minimally. Lumbar vertebral bodies, intervertebral joints, spinous and transverse processes are going to be seen. And you're going to have the SI joints in the sacrum. No rotation is evident by symmetry of the transverse processes, SI joints, and sacrum. Spinous processes are midline. Optimal density and contrast with no motion. And the soft tissue margins and sharp trabecular markings are clearly demonstrated. Lateral lumbar spine, SID is 40 inches. Make sure the patient is positioned so that the lateral part of their body is going to be closest to the IR. They're going to be lying on their side with their hips and knees flexed. Now this can also be taken with the patient standing. The part is going to be positioned with the center of the mid-axillary line of the body to the table. Place a radiolucent sponge under the lower thorax and adjust the spine parallel to the table. And the center ray is going to be perpendicular to 1.5 inches above the iliac crest. And you want to expose the image at the end of expiration. When you're evaluating the image, you want to make sure you have L1 through L4 vertebral bodies, intervertebral joints, and foramina and spinous processes. You want to have the vertebral column parallel to the IR. Intervertebral joint spaces and foramina are open with no rotation. Optimal density and contrast with no motion. And soft image markings visible and bony detail of the vertebral bodies, joint spaces, and spinous process. Lateral L5S1, what we usually call the cone down, is an SID of 40 inches. The patient is going to be lateral with the hips and knees flexed. You want to center the mid-axillary line of the body to the table, extend the arms forward, and place a radiolucent support under the lower thorax and adjust the spine parallel to the table. For the central ray, if the entire spine is parallel to the table, then you're going to make sure you are perpendicular to a point 1.5 inches inferior to the iliac crest and 2 inches posterior to the ASIS. If the entire spine is not parallel to the table, you want to angle 5 to 8 degrees caudad. The respiration is going to be suspended, and you're going to evaluate the image. You want to find an open L5S1 vertebral bodies, intervertebral joints, and foramina and spinous processes. Intervertebral joint spaces and intervertebral foramina are open with no rotation. Optimal density and contrast with no motion. Soft tissue margins are visible and bony detail of vertebral bodies, joint spaces, and spinous processes. Here is an oblique view of the lumbar spine. One is taken with the patient AP, the other is taken with the patient PA. 40-inch SID. Patient can be supine or prone. You want to rotate the body 45 degrees from supine or 45 degrees from prone. The central ray is going to be perpendicular to L3. You want to have 1 to 2 inches above the iliac crest and 2 inches medial to the raised ASIS. And you want to expose on suspended respiration. Image evaluation, your LPO and your RPO, you're going to have L1 through L4 on the downside, zagapophyseal joints. Scotty dog elements are visible. In the LAO or RAO, you're going to have a L1 to L4 upside, zygapophyseal joints. Scotty dogs are the elements that are visible. You're going to have zygapophyseal joint and pedicle, which is the eye centered on the vertebral body. Optimal density and contrast with no motion. Soft tissue margins are visible in bony detail of vertebral bodies, joint spaces, and the elements of the Scotty dogs. Now, in the image, you see arrows in the photos that are going to be above, indicating the zygapophyseal joints. Sacrum X-ray, AP axial, 40-inch SID. Patient is going to be supine. You're going to center the mid-sagittal plane to the center of the table. Your center ray is going to be 15 degrees cephalic, 2 inches superior to the pubic symphysis. You're going to make the exposure during suspended respiration. Your image is going to have non-foreshortened image of the sacrum, sacrum free of superimposition and sacral foramina visible, optimal density and contrast with no motion. Soft tissue is visible and sharp bony detail. For the lateral sacrum, you're going to have an SID of 40 inches. You're going to make sure that the patient is lateral with the hips and knees flexed. You want to make sure that the patient is positioned where there is support of the body to place the long axis of the spine horizontal. The center ray is going to be perpendicular to the IR, entering 3 to 4 inches posterior to the upside ASIS. And your respiration is going to be suspended during the exposure. It's also nice to put a lead blocker at the back of the patient's pelvis to absorb the scatter radiation. On image evaluation, you're going to see a lateral view of the sacrum and coccyx, a lateral view of L5S1 intervertebral joint, no rotation evident by greater sciatic notches and femoral head superimposition. The entire sacrum and coccyx are going to be included, and you're going to have optimal density and contrast, no motion, and the trabecular markings are going to be clearly demonstrated. AP axial view of the coccyx, 40-inch SID, patient is supine. You want to place the part with the center mid-sagittal plane to the center of the table. The center ray is going to be 10 degrees caudate, entering 2 inches superior to the pubic symphysis. Respiration is going to be on suspension, suspended respiration during exposure. And in image evaluation, you're going to have a non-foreshortened image of the coccyx. The coccyx is free of superimposition and no rotation. Optimal density and contrast, no motion. Soft tissue is going to be visible in sharp bony detail. Lateral coccyx, you're going to have a 40-inch SID. The patient is going to be positioned lateral with the hips and knees flexed. The part is going to be positioned with the center of the coccyx to the CR and midline of the table and or IR. The coccyx is located superficially between the buttocks, slightly superior to the lever of the greater trochanter. The center ray is going to be perpendicular to 2 inches distal to the level of the ASIS and 3 to 4 inches posterior. And you're going to make the exposure during suspended respiration. The image evaluation, you're going to have a lateral view of the sacrum, but more importantly the coccyx, a lateral view of L5S1. No rotation is going to be evident by the greater sciatic notches, and the femoral heads are going to be superimposed. The entire sacrum and coccyx is going to be included. You're going to have optimal density and contrast with no motion, and trabecular markings are going to be clearly demonstrated. Here is a SI joint, sacroiliac joint, and this is the AP axial view. Patient is going to have an SID of 40 inches. Patient is going to be supine. The part is going to be positioned with the center, the mid-sagittal plane to the center of the table. The center ray is going to be 30 degrees for males and 35 degrees for females, cephalic, entering below the level of the ASIS. You're going to shield radiosensitive tissues as well as gonads for men. And respiration is going to be suspended during exposure. On your image, you're going to find a non-foreshortened image of the sacrum. Sacrum is free of superimposition and sacral foramina are visible. Optimal density and contrast with no motion. Soft tissue is visible in sharp bony detail. Another view of the SI joint, you will take 2 of these, and this will be your posterior oblique. You will take 2. You're going to have an SID of 40. Patient is going to be positioned supine. You want to elevate and support the side of interest 25 to 30 degrees from the table. The part is going to be positioned aligning the SI joint to the CR and to midline of the table and our 1 inch medial to the upside ASIS. You're going to make 2 exposures. You're going to take the patient this way and turn him the other way. You're going to shield the radiosensitive tissues as well as the gonads for males. And the central ray is going to be perpendicular to the IR, which is 1 inch medial to the ASIS. And this is going to be taken during suspended respiration. Scoliosis series, patient is always PA, and this is going to reduce the dose to the radiosensitive areas. Patient is going to be erect and not wearing footwear. You're going to position the part erect with the spine aligned to the center to the midline of the image receptor. There should be no rotation of the thorax or pelvis. And the central ray for the lower margin of the image receptor is going to be 1 to 2 inches below the iliac crest.